First of all, really, really grateful for excellent three speakers. I thoroughly enjoyed each single slide. It was highly educational, highly informative, and it shows the huge task you've actually achieved by producing these guidelines. So really, really very impressive. And thank you so much for being with us here today. So now it gives me a great pleasure that I welcome the panelists. So we have Anne Vincent, who is a person living in obesity. She also an expert in psychology. Dr. Jennifer Logue, reader from the University of Lancaster. Dr. Stuart Flint, associate professor from the School of Psychology at University of Leeds. Dr. Adrian Brown, NIHR research fellow and specialist dietitian at UCL London. Dr. Stephanie Giorgio, a primary care physician with interest in women health and obesity, and she works in Kent in the UK. And Dr. Carly Hughes from Fakenham Weight Management Service in Norfolk, and she's a primary care physician. And obviously we have all the three speakers. So I'll start with the question to our Canadian colleagues. So the questions I've dotted on my paper are balanced between trying to reflect on some of the UK related aspects and also to try to learn from our Canadian colleagues from their guideline processes. So the first thing is, what was the feeling amongst you when you were writing the guidelines regarding the term lifestyle intervention? Is this a term that you find people accept, patient accept, or is it actually stigmatizing by itself? Should we ban it, or should it be still be part of when we talk about obesity to call it lifestyle intervention? I'll hear from all of you, but who wants to go first from my Canadian colleagues? Sean is smiling. So Sean, do you want to go first?
Yeah, I was smiling to say that Denise and Sarah should go first. That's so I've always had a challenge with the word lifestyle intervention. So it's not some of my favorite words. I would like to be specific. I want patients to know what it is specifically we're doing. When physical activity is important, we talk about physical activity and how it's going to help them with their overall health, but not necessarily have a huge impact on weight, but it's the thing that they can do, and in a very short period of time, things will get better. Their dementia, their risk of dementia ends up decreasing. Their diabetes gets better with physical activity if they can do it. So we have to work to not stigmatize and blame and shame people when they can't do certain things. So the idea of lifestyle intervention always and people stating, you know, I know what I need to do. I just need to do these lifestyle interventions and I'll get it right. No, you need to do the things that are able to help you to maintain the behaviors and the lifestyle interventions. So let's talk about those and components and things like who values you and why you're doing what it is you are doing. So I sometimes start with not the lifestyle interventions, but why they're doing what they're doing, who values them, and who they value to be able to maintain the quote unquote lifestyle interventions or behavioral therapies.
Thank you very much, Sean. Sarah, do you want to add anything to that?
Yeah, I've used the term in the past. I hate the term. I think it should be changed. But like all things, you know, language evolves and adapts. And I would also follow on from that. I actually do think it is stigmatizing. It really does focus on individual, and we have to recognize that environment. And I, at this point, also want to just say there's another word that I think is bandied around still a lot, and I've used it again in the past, and that's obesogenic environment. I actually don't use that term myself anymore. I use the term health disrupting environment, because this is an environment that impacts everybody, not just people who are living with obesity. And I think we have to recognize that lifestyle is in a similar vein, is something that it has very specific connotations, but we need to make environments healthy for everybody and enable people to adopt and maintain health behaviors that will enable them to achieve better health all round and better well-being.
Thank you very much, Sarah. Denise, do you want to add anything to that?
I do, actually. I think one of the things that's really important is that we recognize that there's so many factors going on in people's lives that are entangled and that affect their ability to be healthy. And so, you know, the person who's working 3 jobs to support their families, people who don't have food in the cupboard at the end of the month and can't make ends meet, who may give the fruits and vegetables to their kids. There's many, many things that go on in people's lives that affect their choices and their ability to be able to do things to be healthy. And so simplifying it again down to a notion of lifestyle completely misses the point that this is not always a matter of choice. In our group, the other thing that we really focused on the last several years is moving into this notion of collaborative deliberation, where it's really about situating the treatment plan in the context of the person's life world, and then making plans and activities together that actually fit, that they actually can do. And always around value-based goals, things that really matter for people. And I find that shift is really important, and it recognizes that this is just such an incredibly complex condition.
Thank you, Denise. Anne, I would like to ask you two questions. The first one, you as a person living with obesity, what do you feel about the term lifestyle intervention? The second one is your actually reflection on what we've heard from the three speakers. How do you see these guidelines as a person who is living with obesity?
Thank you, Abd. Well, how do I feel about the language? I think I've got to that stage in my life whereby I don't care anymore. All of this is nothing new to a person who's living with obesity, particularly a person sort of my age. We've heard it, we've felt it, we've lived it. So it's none of it is new. I guess what my understanding of the guidelines, I have to say, is completely different, having listened to the speakers, to what it was when I read the documents. I really appreciate the fact that there's more emphasis put on the psychological aspects of obesity, because I think there is, well, I honestly believe that the psychological aspects are vastly underrated. I think there's a huge thing there, and I really appreciate seeing that in the guidelines. I also believe that to make this work, it isn't going to be just about telling healthcare providers to mind their manners and to treat people with respect. I think all of the big societal changes, and this is what obesity is, I believe. I believe that it's going to take a paradigm shift to get this up and where it should be. All the other big societal changes have all had an event to spark them off. You think about sort of racism, and you link it with the civil rights movement. You think about gay rights, and you link it with Stonewall. You know, things have to have an event to trigger them off. And I think that no matter what we do in obesity, I think that there's going to have to be an event to get that societal change, to change people's attitudes and opinions. You know, I mean, if it was just a case of sort of telling sectors of society that, you know, you've got the wrong idea about obesity, this isn't what, you know, or what causes obesity. It isn't all about eat less and move more. They don't necessarily believe that. 50 years ago, there was people going around saying, well, you know, it's in your genes. We now know why it's in the genes, which we didn't perhaps know then, but we were just ridiculed. And even now, I've heard people turn around and use that same phrase. Oh, they're going to say it's all in your genes again. Well, it's not. It's about what you put in your mouth. So I think that these guidelines are great. I like the fact that you are sort of advising healthcare professionals to look at a holistic method, because that's what it's all about. And I really hope that there is a change with them. But I'm not holding my breath, because I honestly believe it's got to be at societal level for the change to be made. But well done, and thank you so much for taking, you know, sort of a person-centric approach on this, because it's the first time in 55 years I've heard it.
Thank you. Sorry, I was muted. Thank you very much, Anne. If anybody want to add anything, just wave your hand so I know you want to speak. And obviously, I'll give the floors to you. But very insightful, and thank you very much. So that takes me to Stuart. Stuart, so what can we do about obesity stigma? I mean, within the healthcare system, within the wider society, it's certainly a big problem within the healthcare system. We all know this. All the people on the screen know that. What can we do about it?
Well, I think there's a range of things that we can do about it, and Anne touched on that in terms of if we're really going to address stigma, whether it's in healthcare or anywhere else, there needs to be a concerted effort where we're looking at a whole system approach to stigma itself, and the narrative that's ultimately used in and around obesity, but weight more generally. And actually, linking to what Anne mentioned, and I think Sean mentioned at one point about certainly improving education around the complexity of obesity being one of several ways of potentially addressing bias. One of the questions that I was going to have for the team actually was I picked up on Sean's comments at the start of your presentation, Sean. Thanks for your presentation, by the way. Was that Dr. Patton and other colleagues identified that you yourselves as researchers at healthcare professionals hold biases, and you were biased then. And so I'm quite interested how you guys as a team have addressed those biases. And because certainly as part of your guidelines, and I totally agree with you, we need to address bias in healthcare professionals themselves. So, what are some of the different things that you guys have done yourselves, and maybe could be learning opportunities for healthcare professionals elsewhere?
Yeah, so I can try and speak to that. So running a large obesity clinic, so we try to put things in place where we have some rules and regulations where we talk to every patient about the options. So no patient leaves the clinic without hearing all of the potential options. So we try not to have our own biases. Somebody who is living on social assistance, they're not going to be able to afford medication, so I won't talk to them about that. Or this person is in a position where I don't think they look like they'll understand bariatric surgery. I'm not going to, nope, not an option. The only option is to talk about every single option that is available to the patient and for the patient to help them to make the decisions. So take our decision out of it, my own biases about who is sitting in front of me, and ensure that I do the best that I can. I even write down the language so that I can say the words in a similar manner to all people. If you leave it to me, by myself, I'll just come up with biased language for different people at different times. So, and that's what we do within the, that's what people are trying to do in multiple other fields, in women trying to establish themselves as CEOs and in other positions. It's not just going to happen. It happens with rules and regulations, because why would anybody let that necessarily happen? It happens because of guidelines and structure, because we cannot and should not trust ourselves. We should believe in ourselves. We should be good. We should not blame and shame ourselves, but we shouldn't necessarily trust ourselves. We're born with bias, where we have developed bias, and it's ingrained. I'm 51, and there's no way that I'm easily getting rid of my biases. So I need rules and regulations to help myself do better.
Yeah, I think some really great points there, Sean. And what I'd like to maybe do is probably go to Sarah, because again, some great information from you, Sarah. And maybe there's something further you could add there. But maybe also, within the guidelines, we're also talking about how do we, support, people who have internalized weight bias, because that's one of the key parts of the guidelines. And maybe, you could, add some information about how you effectively support, people with addressing their internalized weight bias.
Actually, what I'm going to do is just let you know about some of the things we've done to try and address healthcare provider biases. So I led a study a few years back now where we looked at obesity management in the province that I'm in, which is Nova Scotia, across multiple levels. And so we looked at individuals living with obesity, healthcare providers and policymakers. And what we did from that, actually, we got such rich data. So it was qualitative research, it was very, looking at narratives and the discourse that was happening across these three groups. And we actually ended up developing a dramatic presentation. And we then incorporated that into a knowledge translation event. And ultimately, that's actually now formed an interprofessional education course. I actually run that in the winter term. So in January, I'll be running at Dalhousie. And we run this with students from the health professions. And basically, what we've done with the drama is incorporated into that. So they watch the drama and then they rewrite the script so that they actually can change their language in almost like real time. When we could do this live, we actually used to have the students write the script or rewrite the script and then have the actors come and play the parts and read them out so that they could even hear how it sounded. And we've had tremendous success with that in terms of reducing weight bias and stigma in the students that we have. So we now do it online because of COVID. But actually the other reason we do it online is because of psychological safety. So some people with obesity, when you're dealing with weight bias and stigma, actually that can feel that's a very difficult place to be. And so we really wanted to take that out of the equation so people can speak freely about their experiences and nobody actually knows what they look like. So it's actually been really helpful. And so that's something that I feel we really try with that interprofessional course to help people speak and feel safe in doing so, and also recognize that their biases are there. And as Sean says, we all have them, but we have to learn how to manage them. And that's a process, a real process.
Thank you, Sarah. Stuart, I just want to check, was it your mobile that failed or you failed?
Both.
I'm glad you are still well in one piece.
Just about.
Thank you very much.
That's great. Could I just maybe follow up my second question as well? Because I think it's certainly a very important point around internalized weight, but addressing internalized weight bias, because as we do know from the data, and of course you touched on that, of course, in the guidelines, the association between weight bias internalization and in particular mental health concerns, and I think there is a key part of these guidelines. So I'd certainly like to hear a bit more about how you guys work in terms of weight bias in Canada.
And I think there is a lot of us, a lot of people sitting around this table, or virtual table, who will need to do, actually, we need to think more about what can be done from addressing the biases in amongst healthcare professionals. No question about that.
I think I can probably chime in a little bit about the internalized weight bias question based on the behavioral chapter and Michael Vallis and colleagues work in that space, and probably Sean can as well. But I think one of the issues is to listen hard when you're talking to your patients. So I'm a family doctor, and to listen to what they're telling you about what they're telegraphing about what they believe their worth is to be treated. And that's also the really, I think, key point about the asking permission to even talk about the topic and leaving the door open so that they're in the driver's seat about bringing that up, because there's many, many things in their health we can be addressing independent of their weight if they're not ready to talk with us about that. And I've had those experiences of people coming back and saying, I'm ready to talk about it now. And then the second piece is that's one of the reasons that we created the primary care framework that we did for how to conduct that original consultation, which is really listening to the person's story and seeking to understand their story, and then co-creating new meaning together with a new story to come up with a new action plan. And there's links to that in the guidelines. And it really comes down to this, helping people understand when they're saying those things that telegraph that they're not worthy of treatment, and helping gently redirect that. And then if it's really significant, I think there's a role for cognitive behavioral therapy and acceptance commitment therapy. There's evidence around those types of therapies with a professional psychologist to help people reframe some of those negative patterns of thinking. And so again, the stuff which is intrinsic, as what was speaking of before, I mean, those are things that are tricky to change. But the higher order, then how does it actually make us think? Those are places where we actually can intervene. So those would be a couple thoughts I would have on the internalized weight bias.
Thank you, Denise. That's extremely helpful. I'm going to shift gear and move to slightly more practical implications to the UK healthcare system, and the other four panelist members who haven't spoken yet. I'm going to ask you one by one what you think about certain aspects. I'll start with Stephanie. Stephanie, I like personally, I like the 5 A's. I use them in my clinical practice, but my appointments are 45 minutes. Do you think, as a general practitioner in the UK with a 10-minute appointment, how would you use the 5 A's? Use them? They need to be modulated or changed to fit the UK healthcare system? Do they need to be done on more than one appointment? What are your views?
Yeah, I mean, I think the 5 A's are brilliant. I've just written something for some UK GPs, and we have referenced this massively because I think it's such a useful framework. Yes, it's not going to be done in a 10-minute appointment, and one of the things that I think is really important is that we don't try. I think that we risk doing it badly. I think the most important thing, basically following on from what Denise said, is the first thing you should do is listen to the patient and take that weight, ask permission. So make sure that it's not, if they've come in with something else and that's serious, don't even try. Ask permission to discuss it at another time, leave the door open, and then they can come back to talk to you. And that the appointment needs to be just about that. And that's tough because at the moment we have, we're in the middle of a slight global pandemic and there aren't many appointments. But if I think about it for afterwards, then yes, it will be more than one appointment, but we use more than one appointment for lots of things in primary care. We don't try and deal with someone's diabetes in one appointment. And it may be that we use the primary care team around us, but I like the 5 A's. I think the most important thing though is starting with that listening, because until you can show that you understand the internal bias, the history that person has had, the importance of taking that proper weight history based on that person's life, until you've done that, you've lost them. You're never going to get them on board. And so using your time well to do that is the most important thing. And then we can signpost as necessary. It may be that we do a direct referral onto the tier 3. But we need to use our time for the most effective intervention, and the most effective intervention is not talking about quinoa. It's understanding, listening, and showing that we get it.
Thank you for that, Stephanie. Carly, please.
I'd like to come in on that one because I do agree with Stephanie. And also I'm in an unusual situation that I'm a GP with 10-minute appointments, but I also work in a tier 3 specialist service where I have 30-minute appointments. And what you can do in those two different settings is very, very different. But I absolutely agree, asking the permission and doing that listening at the beginning is the best thing that the GPs can do. And we have to accept that not every GP will have a major interest in weight management or the time to do it. And if we recognize that, but just train them to be empathetic and to know the appropriate pathways to refer people on, and to have services available to refer people to, and services with a whole range of skills, including the psychological interventions, then that's the way that we can go forward and provide proper care. We've got to address stigma, but I'm worried about the idea that thinking that every GP is going to really completely engage with this. I think we've got to be realistic and get rid of the stigma and improve the route through into appropriate pathways. But in a 10-minute appointment or even repeated 10-minute appointments, not everybody is going to be able to do it. And there is a danger that GPs will do it badly. And there is, this has happened. And sometimes it's important to recognize what you can do and what you can't do, and get people to the appropriate service. So this whole systems approach of having the right services to send people to, very important. And I did want to pick up, I think it's great to recognize that psychological intervention is not lifestyle management. It's a very specific and important, I really love that point, because we're not good in the UK in it. We're very woolly about things like that. We're not good at commissioning psychological services. And yet within my tier 3 service, I really see the value of unsticking people and enabling them to move forward by dealing with the psychological issues as well as the biological ones. So I thought that was a really important point. I really liked that.
Absolutely, Carly. Thank you very much for that. And I was going to come to you to comment on this as well, because obviously it's your field of expertise. I'm going to ask Adrian and then Jennifer, and we might be running just 5 minutes late. I hope that's okay with everybody. We are not finishing yet. We're just about to finish. But Adrian, one of the points that I always struggled with personally in the UK or in England, let's say, is that people do not focus on the root causes of obesity. When you go to the clinic, the first description is, although the words will vary, but basically they eat too much and they move not much. And that seems to be the end conclusion of every obesity consultation. And people always fail to understand what is the underlying cause of the behavior, and they fail to identify it. First of all, how do you think we should approach this? And how can we change that mindset amongst clinicians and dietitians who are working in the field to try to work to understand the underlying causes?
Thank you very much for the great question and inviting me here today. Can I just say the Canadian guidelines are fantastic. I'm jealous. I'm thinking about moving to Canada for them. So they're absolutely brilliant. And having read them, they're a real, they're fresh air for the thing. You can see where the evidence has come from. I think related to your question, Ab, I think there's a lot related to education, and I think it was come out in various talks today related to attempting to educate the wider society, and particularly even people working in obesity management, about the complexity of obesity and the fact that genetics plays a role, the environment plays a role, the fact that psychology plays a role. And we still, unfortunately, the message is being drilled down from our government. When you look at obesity guidelines, often what happens is it's simply eat less, exercise more. And unless we actually change it at an actual national level about the driving message that this is highly complex, I think we're going to struggle. So I really think that education is going to be the key coming forward, and about how the guidelines change in terms of the underlying message related to treatment. And one size doesn't fit all. And that's what I absolutely love about the medical nutrition therapy section, is that that's there. It's not, when you look at our guidelines at the present time and you look at what's advised, it is an Eat Well guide. It's not actually choose the right dietary method for that person who's there in front of you, speak to them about what works. It's very much a one size fits all, which is in part of the issue. So yeah, I hope that answers your question.
It does indeed, absolutely, perfectly well. And I just want to add, I mean, as a clinician, I'm not a dietitian, of course, and I don't have Adrian expertise, but I hardly ever ask the patient what they eat, because it doesn't help me. I mean, what they eat is what they eat. I want to understand why they eat, and how is that influenced by their environment and by their work schedule and by their sleep schedule and by their genes and the rest of it. And the other medications they've taken and prescribed by our psychiatry colleagues, etc. Totally agree. Jennifer.
Indeed.
Taking Adrian's point forward, which is, we know our guidelines in the UK are sort of terrible, and there is a lot of focus in the UK about weight. I mean, weight is the most important outcome measure when you talk to commissioners, even when you talk to NICE. Everybody wants to talk about weight, and we want to shift this, that this is about health, not weight. How can we do that?
Okay, so there's kind of two different parts to this. Of course, I fully agree that health and actually I think well-being and many other measures that are important to people are the most important measures. But there's some things that are quite useful about weight, in that it's easy to measure. It's something we can do everywhere, and it is something that understands, and it does maybe not necessarily on an individual level, but if you're looking across services and things, it is something that generally correlates well with a number of the health outcomes. So there's two sides to it. I don't think it should be the only outcome by any means. And I mean, you know, I'd rather we looked at health, and I mean, I probably have more of a medical focus and look at obesity related diseases and that, and thinking of you know, this is as in terms of multimorbidity and how we manage disease clustering. But then at the same side, you know, you're also talking about things like work, you know, health, well-being, and the things that actually motivate our patients, such as being able to go on a plane without being completely panicked about it, being able to push your grandkid on a swing at the park, that type of thing. We're never going to be able to write a report for commissioners that tells us how many people felt comfortable pushing their grandkid at the park. So we have to be realistic, and actually that's the same with quite a few of the things we can talk about. There's even going back to the very original question about behavioural weight, well, lifestyle weight management, as you called it. I've now moved on to trying to call it behavioural weight management, but I realise even that in itself. But there's what we write in papers, there's what we talk about with commissioners, and then there's obviously what we actually talk about one-to-one with patients, and we do use different language. Yes, we need to realise that we're not making things worse by the language we use, but we do need to realise that there's different horses for different courses, and weight has got some purpose in this. Thank you very much for that, Jennifer. If no other points to be added, I know we are running 5 minutes late. We could talk about this for another hour, but we all
I had one final point.
Oh, Sean, please.
I just want to ensure that everybody as well recognizes that one of the big things that our patients told us is that always end everything with hope. A lot of the times when we talk about the pathology and I talked about the brain and then the genetics, it codes for this increase in opioid receptors in the brain. That doesn't just sometimes tell people about hope. It tells them about pathology. But what we want Anne and everyone else to know is that there are good things that are out there right now. And your patient who doesn't have any idea about weight management issues is that I'd like to talk to you about weight. Do you know why? Because there's really good things that have happened in the past 20 years. 20 years ago, we did not have bariatric surgery. 20 years ago, we did not have the medications that we have now. 20 years ago, we did not know about cognitive behavioral therapy the way that we do. The three main pillars that we're using for weight management in the 1970s and the 1960s, we didn't know about them. We said eat less and exercise more. So there's so much hope because there's so much more positivity. It came from understanding the pathobiology and the biological process and everything else. But the patients need to know that we're not giving them more disease and more problems and more genetic things that are bad for them. No, we're giving them hope and recognition that we're on the right path.
I absolutely agree. We have so many tools now that not only we can improve the outcomes, however you want to measure it, weight, health, or quality of life, or complications. We have so much better tools at the moment. Thank you so much for that, Sean. So it gives me a great pleasure to say thank you very much to the Obesity Canada team, all the speakers, ASO, Novo Nordisk for the sponsorship, all the panelists. It's been really a great pleasure to have you with us here today, our last webinar in this year. So I wish you all to have a Merry Christmas and a Happy New Year. And I will have to run. I will have all sorts of biases now because it's my wife's birthday. So I really need to disappear in the very near future. So thank you so much all. And I wish you a very pleasant evening. Take care of yourselves.